Aditya MAITRAY. He's going to talk about real sequelae of peripheral avascular retina case series.
Can I start? Yeah.
Slides, please.
Yeah, good afternoon. So as we know, slides are not moving. Can you reset the timer, please? Can you reset the timer once? Yeah. So as we know that the common causes of peripheral avascular retina could include either physiological, which is secondary to high myopia, prematurity, FEVR and related retinopathies, Coats disease and PFV. So we did our own analysis of our documented cases of PAR with good imaging documentation, and we could see that the etiologies are similar to what I just mentioned. So I would just like to highlight some of the interesting cases here. Case 1 was this 10-year-old boy with history of extreme prematurity. Right eye had a the right eye had a ROP sequelae-like picture with atrophic retina and CRA patches. It was the left eye, which was a good eye, which has now developed reg RD, as you can see, with multiple breaks in the avascular retina beyond the old wrist tissue. Now, this boy did well, fortunately, with the buccal surgery, and the retina settled. Case 2 was a 21-year-old girl with decreased vision since childhood in both the eyes, and she had a history of prematurity and intellectual disability. The anti-segment showed axon-filled anomaly and an early PSC in both the eyes. But the fundus picture in the right eye showed these fibrotic bands in the vitreous connecting to the retina, some sclerosed vessels, an active VPT lesion, vasoproliferative tumor in ITQ with exudation, and significant amount of PAR with vitreous condensations. This was very well highlighted on the FFA, showing the PAR and the leakage from the VPT. The left eye was even more drastic with dense these fibrotic bands causing traction, significant chronic exudate in ITQ from an old VPT lesion, and a peripheral avascular retina. Additionally, this child had a history of cleft palate surgery done and had dental anomalies. So we were not just looking at a ROP sequelae here, although there was a history of prematurity. So we did because of these features combined, did not make the sense in terms of prematurity. So we did a genetic testing, and we could get a LRRC32 mutation, which is a TGF beta receptor gene coding mutation. And this, to our surprise, was reported to have an exact picture in the previous literature in terms of proliferative retinopathy and systemic features similar to what we saw. Then this case 3 was just a 16-year-old boy with Coats disease and an active VPT lesion in ITQ, and this is well highlighted on this FA image with PAR, telangiectasia, and the leaking VPT. And he did well with the cryo and to the VPT and peripheral laser. This case 4 was interesting. A young myopic girl with just came for a routine examination for myopia, and she said he had a history of barrage laser done to the right eye in the past. But as you can see, there are clear features of FEVR with dragging of temporal arcade vessels, peripheral avascular retina, these fibrous NVs in the periphery, and a VPT lesion in ITQ. So this was just not a high myopia, and the FFA beautifully highlighted the leaks from the NV and the VPT lesion, and the PAR also was well highlighted. Even the left eye had signs of FEVR with PAR seen on FFA. So finally, this case 5 was a 13-year-old girl who presented with decreased vision in the right eye for past 6 months. She had a syndromic facial appearance and nystagmus in both the eyes. When we saw her, the right eye showed a chronic retinal detachment, inferior retinal detachment with SRG bands, and some CRA patches at the macula. The evaluation under anesthesia showed these, the temporal periphery had this pre-retinal fibrosis with overlying vitreous condensations, producing retinal folds and schisis, probably causing the RD. The left eye had a similar CRA-like patches at the macula, symmetric, and the periphery showed these fibrotic NVE and PAR beyond that, which was well highlighted on FFA images. And to add to the confusion, there was the ultrasound picture showed a nanophthalmic appearance with extremely short axial length and increased RC thickening. So this was an atypical combination of FEVR-like features with nanophthalmos, which we have not seen before. So we advised genetic testing, and also the right eye did well with post-buccal surgery, and the retina settled well. However, the genetic testing did not reveal any likely or pathogenic or likely pathogenic variant. So the take-home message is that when we see a peripheral avascular retina, we should have a thorough history taking, and also should have a both detailed systemic as well as ophthalmic evaluation. And genetic testing can be considered in cases where the diagnosis is uncertain or where the features do not add up to a expected diagnosis. And most importantly, with the growing group of people with the increasing use of anti-VEGF monotherapy in ROP, there's a rising population of children who are growing up with a peripheral avascular retina, and they will need a good routine indirect ophthalmoscopy for detecting these PR-related complications early. And since these children do not really cooperate well for peripheral exam, there is the role of additional wide field imaging, where, as you can see here, without the wide field examination, the findings can be easily missed. Thank you.